Well, good evening, everyone. It's this time of the week again, week number 7. Can we just get a quick sound check? Can everybody hear me? Excellent. Thank you very much. So here we are again for another week of ECGs. It's been another ECG Manic Monday. So good to see the usual crowd out there, which is nice to see. Thank you for being so loyal to us. And giving up your Monday evenings again. So we'll just we won't rush on too far ahead, just in case anyone else wants to join us. So I see we're basking in sunshine down here in London. I see the weather's not so great further up north by the looks of things, but we're doing okay. So a bit better than it was yesterday anyway in the morning. Not fair. Well. Excellent. So just the intros, see a few people just arriving. So welcome to the weekly ECG webinar series. We're now into week number 7. So tonight is the Tachycardias and Wolff-Parkinson-White, which is obviously a subject a lot of people want to know about. So I'm Ines, the paramedic practitioner. So I've got a special interest in cardiology and ECGs, and my company STC Training Solutions is doing this range of webinars for healthcare professionals, and ECGs is the first in hopefully a long series of subjects, and we're starting now to plan the second series, which is going to be bloods and haematology, possibly a bit of immunology built into that as well, which will be starting in a few weeks' time, as we are kind of running towards the end of the subject material for ECGs. So if there is any subjects you or anybody you know wants covered, then do give us an email, and we'll make sure that's ticked off before we move on to the next series. So yes, so as I say, STC Training Solutions originally set up as a first aid training company, also a FREC or QA QualSafe FREC centre. We do the FREC range of courses. So of course, please do spread the word. The ECG webinar series, we'd like to remain free of charge, obviously with the benefit of it bringing customers in through recommendations and getting to see the teaching, etc. So the obligatory plug starts now. So since I have updated this slide, and the FREC 3 on the 18th of July is just sold out this evening, so so that's no longer available. More than welcome to join the wait list in case anybody cancels. Obviously we have a good cancellation policy, so people can leave up until 7 days before, so free of charge. So if you want to join the wait list, in case anyone does that, you're more than welcome. Or if you know of anyone that's interested, the next one starts on the 29th of August. So we made a bit of a change from the next course, the 29th of August. We'll be including gases as standard. Just to give the Entonox qualification, which I know a lot of people that are going through the FREC pathway mention, it seems a bit silly you don't get Entonox until you get to FREC 4. So we're going to include that as standard. Life-saving meds has been very popular. Next course starts on the 4th of July. That is selling out very fast. We've had a huge amount of interest in the last day or two. Thank you, Matt, very much appreciated for that recommendation there. So Matt joined us on our last one this weekend. Since we've shared the photos of that going ahead, we've had a few people interested. So if you know of anyone that's in the market for safe administration, life-saving meds, the more interest we get, the more courses we'll put on, quite simply. So we've got one planned for the 4th of July anyway. And ILS, obviously our ILS course includes mechanical ventilation, eye gels, and manual defibrillation. All as standard. We run it to the RC UK standard, although we're not yet an RC UK centre. So if you want to come along for a really good day of ILS, then please get booking. We'll be running hopefully one of those a month once we get kind of properly up and running. So I know there's not been a huge amount of interest, just because QualSafe have extended the requirements quite clearly with COVID, that people don't need to have done their ILS bang on a year. So any of those interest you, or if you want more information, then sales@stctrainingsolutions.co.uk. And with that then, so it's 7:05. We've got a few more joined. So we'll get on with the subject in hand, which is the ECGs tonight. So we're going to try. We've done an update on some of the software tonight. I'm going to try Mentimeter again just to see whether that causes us any issues. So let's keep our fingers crossed. So we are using Mentimeter in the standard way tonight. So do grab your smartphones. The more of you that answer the questions and have a go at the questions, even if you don't have a clue, it does make it a bit more interactive and you're more likely to learn from it. So if you need to ask anything, Charlotte's in the chat as STC admin. You can WhatsApp us, you can tweet us, and you can email us. And of course, all of those apply even after the webinar has finished, or if you're watching this on YouTube later on, do get in touch if there's anything you'd like to know about ECGs or anything about the company. So you can't do an ECG webinar on tachycardia without this, can you? Don't be tacky. You see it around Christmas, don't you? But why not? We'll bring it out now. So on we go. Tachycardias then, so literally means fast heart. So we're going to do a little bit of introduction, a bit of classification by the different types of tachycardias, broadly speaking, and how we then break them down. So tachycardias people get confused slightly because in most cases you have to slow them down before you can diagnose them, but there are some hints and tips, particularly when we talk about the wide complex tachycardias later, to kind of give you some idea. So first things we're going to talk about the atrial tachycardias, those that come from above the atrioventricular node, so from the SA node and other kind of cardiac myocytes that are capable of producing pacemaker signals. The atrioventricular tachycardias, those are going to be those associated with the AV node at the bottom of the right atrium. So Wolff-Parkinson-White syndrome is a very specific type of atrioventricular tachycardia that we're going to talk about. It's one that people mention that they don't really understand, so hopefully we can bring some understanding to that. And LGL, so Lown-Ganong-Levine syndrome, it's always known as the other one. So if you want to know it as the other one, that's fine. LGL is the kind of, there's Wolff-Parkinson-White, and then people always talk about the other one that they can never remember the name of. That's it. Its existence is disputed. So we'll talk about whether or not it exists and have a look at a possible case of LGL. So, and then to finish off, we're going to talk about how we try and make it tell the difference between some of this when you have a wide complex tachycardia. There are some ways of trying to tell whether it is actually an SVT with some aberrant conduction going on, or whether it is a genuine VT. But you'll see a couple of times it will come up. If in doubt, treat as VT. Okay, and then of course the Q&A session at the end, which will go on as long as you wish with any questions that come up. But as always, as every week, if you have a question come to mind, chuck it in the chat or text us or whatever. Even if we then go on and answer it, it doesn't matter. If we come to a natural pause, it's quite nice to just go look through for any questions that haven't been answered. So we'll crack on in that case. So we're going to a quick throwback to last week when we talked about atrio and ventricular anomalies. I'd like you to have a look at this ECG for me. I'm just going to flick on quickly just to get the Mentimeter code up for you. So menti.com, grab your smartphones, type in menti.com into Safari or your web browser. The code tonight is 83613. Charlotte's going to pop that in the chat. So the question is, what atrial anomalies are present? So LAE, left atrial enlargement, right atrial enlargement, biatrial enlargement, or atrial fibrillation. You get the choice of one. I'm going to flip back to the ECG. The code is menti.com, and the code is now in the chat. If you want to grab your smartphones, have a good look at this ECG and tell me what you think is going on. In terms of the atria, there's lots going on with this ECG. But see if you can diagnose what's going on with the atria. So give everyone a couple of minutes to have a look at that. To say we're not overly fussed about whatever else is going on, and you've got the choice of 4 possible answers. So we're saying this is left atrial enlargement, right atrial enlargement, biatrial enlargement, or atrial fibrillation. Tell me what you think is going on here. So menti.com 83613. I'm just going to flick forward, see how many of you have started voting. 3. Fantastic. 7, lovely. just going to have a look at where people are going. So most people are going by atrial enlargement. I'll just flick back to the ECG so people can still have a quick look. So most people thinking by atrial enlargement, a few thinking everything else. Lovely. Where are we up to? 10. So half of you, 5 of you going for biatrial enlargement. Lovely. A couple going for left, a couple are going for right, 1 going for atrial fib. Okay. So the correct answer is biatrial enlargement. Let's talk about why. It will let me go backwards. So let me get my pen. Oh, what happened there? Sorry, me pressing the wrong button. Okay, so the choices were left atrial enlargement, biatrial enlargement, right atrial enlargement, or atrial fibrillation. So whilst there's a massive first degree heart block going on here, there's your P wave. There's your P wave. Well, there was a P wave starting back there as well in V1 and lead V2. You can see lead 2. You can see your P waves there. So there's it's not atrial fibrillation because there's coordinated P wave activity, and it is producing a QRS complex. Absolutely, there is a first degree heart block going on, without a doubt. So diagnostic criteria, do we remember for right atrial enlargement was the peaking of the P waves, particularly in lead 2, over 2.5 mil in voltage, 2.5 millivolts, sorry. And then looking up at lead V1, we're looking for more than 1 millivolt of negative deflection in a biphasic P wave with a duration of more than 140 milliseconds, both of which we've got. This is diagnostic of biatrial enlargement. You have both atrials enlarged. There are other things going on with the ECG, not only first degree heart block, but that was the correct answer. Well done to more than half of you that got that right. So we'll move on. That was a throwback to last week. You can always have a look at last week's episode on our YouTube channel if that one interests you. So well done. Okay, so a little bit on classifications this evening. So basically, there's 2 types of tachycardias, and they're down to where they come from, effectively. So there's supraventricular tachycardia, which is quite literally above the ventricles, i.e., it comes from above the AV node. Ventricular tachycardia comes from somewhere within the AV node or the ventricles itself. And remember last week we talked about junctional escape and ventricular escape rhythms. If they were to become fast, i.e. over 100, they would be classed as ventricular tachycardias. Supraventricular tachycardias, there are lots more, and they can be, again, they're all hard to differentiate between, and the key isn't to try and necessarily diagnose whilst they're fast. The key is to get them into a normal rhythm and then diagnose what the underlying problem is. So we're going to talk about some of the underlying problems. The first question is going to be, how do you slow these rates down? In most cases, slowing these rates is going to be one or a combination of vasovagal maneuvers. So, blowing into the syringe. Completely forgotten the word. The Valsalva maneuver. Thank you, Charlotte. The Valsalva maneuver, blowing into the syringe, and the modified Valsalva, where you do that and tip the patient over and try not to throw them off the trolley bed. Then it will be some kind of adenosine / DC cardioversion, depending on what's going on. But they're the general ways of slowing things down. These aren't going to be done pre-hospitally necessarily. Adenosine is, but not necessarily going to cardiovert these patients out of hospital. So the supraventricular tachycardias tend to be less problematic, with one exception, that's the Wolf-Parkinson-White, which tends to get to kind of crazy speeds. Ventricular tachycardia is generally less sustainable by the heart, particularly in older hearts, and generally leads to cardiac arrest if it's not settled down. Of course, any additional strain on a heart that's otherwise unwell is not going to be a good thing. So we do like to slow these things down, but some of the SVTs aren't necessarily as life-threatening as their VT counterparts. So lovely. So the classifications then, so supraventricular tachycardia is broken down into either atrial in origin or atrioventricular in origin. There's a bit of crossover with the atrioventricular ones, obviously, and we're talking about the fast junctional escape beats, and then the re-entry tachycardias, which we're going to talk in a little bit of detail about. Atrial tachycardia can be either regular or irregular. So we're going to have a look through what the ideas are. Generally, everything from the AV node down is going to be regular. You kind of lose the ability to have an irregular rhythm, other than in VF and PVCs and other things that aren't generally going to cause the tachycardia. So moving through then, so the golden rules before we go forward: narrow complex tachycardia. So what we mean by that is a narrow QRS complex. So if you look at it, it's fast and it's narrow. They're generally going to be coming from high up within the circuit. We know that from all the other lectures we've talked about the last few weeks. So the higher up the circuit, you start the process from, generally the narrower the QRS complex is. If the ventricles themselves are generating their own QRS complex, it's going to be wide and slow and bizarre. If it's narrow and looks normal, it's probably coming from quite high up in the circuit. The wider and slower it gets, further down. SVT, so anything above the AV nodes, generally, and it's pretty much always true, you do generally need to slow it down before you can figure out what's actually going on. Wide complex tachycardia, so anything with a wide QRS complex that's fast, it's VT until proven otherwise. That's the golden rule. Bear that in mind. If you're not sure it's VT, treat it as VT. Go to an arrhythmia centre, get them to figure out what's going on, slow it down with the right drugs. And you're definitely going to want to monitor that patient. Ventricular tachycardias can end up in pulseless ventricular tachycardia and cardiac arrest fairly easily, particularly with older hearts that aren't going to sustain those rhythms. So when we talk about atrial tachycardias, we get a little bit confused because the group of tachycardias are known as atrial tachycardias, but there is also a particular rhythm known as atrial tachycardia. So of course we like to make things complicated. So sometimes the definition is put in there, or the word to kind of differentiate is unifocal atrial tachycardia. So atrial tachycardia is an umbrella term for a tachycardia that is originating from somewhere near the SA node. And atrial tachycardia as a rhythm itself is actually more correctly known as unifocal atrial tachycardia, and we're going to look at that in a minute. So your bog standard easy ones. So your sinus tachycardia, that is fast heart rate because the sinoatrial node is being ordered to beat fast. Now loads of different reasons for that. Really obvious reasons: exercise, infection, stress. You can imagine all the situations in which a patient would have a fast heart rate, and you'd go, well, that's expected. That's sinus tachycardia, and that is a normal finding, provided it slows with rest and relaxation and all that kind of good stuff. When it doesn't, it's known as inappropriate sinus tachycardia, and that is a resting heart rate, a high resting heart rate, or a resting heart rate of above 100. For no obvious reason. It's actually quite common in young females. They think they're not entirely sure why, but they think there's a hormonal cause behind that. So young females quite often will present into primary care with inappropriate sinus tachycardia as their kind of presenting complaint. They realise that their heart rate's fast. Sometimes we never figure out why. It just kind of settles down. So in an older patient, that's abnormal. You'd be looking to why that is, but again, it generally doesn't happen so much in the older patients. So as I say, what is commonly referred to as atrial tachycardia as a rhythm is more correctly known as unifocal atrial tachycardia. And the reason being, do you remember from one of the previous lectures on lead to arrhythmias, we talked about multifocal atrial tachycardia, MAT, as being one of the irregular tachycardias. So they're brother and sister. Unifocal atrial tachycardia is regular. We're going to look at that in a minute. Atrial flutter, we've talked about it at some length in previous lectures. Atrial flutter and atrial fibrillation. If you look back through our catalogue of webinars, you'll be able to find some more information on those. So they're not going to be covered tonight. But if atrial flutter is more likely to be regular, atrial flutter can be irregular. It's got a variable block. And atrial fibrillation is always irregularly irregular. It can be fast. So this one down here, the sinus node re-entry tachycardia, I couldn't find any examples of it. It's really not that common. It's not that well understood either from what I'm gathering. There's three kind of theories around what's going on in SNRTs or SANRTs, as the Americans like to call it. But so sinus node re-entry tachycardias, there's a bit of a theory that what happens is the some of the cells within the sinoatrial node itself start to fire and reactivate each other, and you get a bit of a circular kind of activation pattern within the SA node, and that causes multiple signals to be sent down the intranodal pathways to the AV node. Now, of course, the AV node isn't capable of processing too many signals because the ventricles are still repolarizing and therefore can't depolarize again. So you have a maximum sustained heart rate, but what you can do is get a very, very fast tachycardia for no obvious reason. So the clinical findings with SNRT are a sudden increase in heart rate and generally a pretty sudden decrease back to normal. It's paroxysmal, it can come and go, there's no obvious triggers for it. And it is associated with kind of ischemic heart disease and things of that nature. So it's going to be an older patient type presentation. That being said, as I say, I couldn't find any examples of it being so paroxysmal. I think if you ever notice a patient having, you know, a normal sinus rhythm, and then all of a sudden they go to a heart rate of 150 or something for no obvious reason, and then back down to a normal speed, it could perhaps be something like SNRT, but it is very rare. And as I say, it's so rare that it's pretty poorly understood. As I say, there's still 3 working theories on what's actually going on. The most likely is just this kind of circular re-entry pattern going on within the SA node, causing it to fire way more than it should be. Okay, it's kind of associated with sick sinus syndrome as well, which is something you can look up because that covers a few different things. So again, looking at the irregular fast rhythms, we're going to be looking at atrial fibrillation with rapid ventricular response, so fast AF, atrial flutter with variable block, multifocal atrial tachycardia, which we've covered in previous lectures, so we won't be looking at it again. And just good old sinus tachyarrhythmia. So, you know, you can have sinus arrhythmia. We looked at lead 2 rhythms. You can, in younger patients, typically, respiratory sinus arrhythmia is a thing. If you have that, then you have a tachycardia, then you have sinus tachyarrhythmia. So that's benign. That's nothing to worry about. And that's just a fast version of sinus arrhythmia. So we're going to look at unifocal atrial tachycardia because that's really one of the only new things here. So the point to mention here is the abnormal P waves. So where you have monomorphic non-sinus P waves. So if you remember that certainly in lead 2 you're expecting to see positive P waves. If you see negative P waves, or if you see P waves that look abnormal, but they stay the same shape, the chances are that the SA node is being replaced by another group of pacemaker cells. They're doing a good job. They're doing a normal job, but in this case, it's beating a little bit too quickly. So a rate of over 100 for it to be unifocal atrial tachycardia, and monomorphic non-sinus P waves, which is seen by abnormal P wave shapes. So we know that these P waves haven't come from the sinus node, but they are regular. There's no changes in those shape. They are monomorphic. So in this case, this is a unifocal atrial tachycardia. So that's the only real new one off that sheet. So the atrioventricular tachycardias, which is kind of the bulk of what we're going to talk about tonight, are divided into 3 things really. So do you remember last week we talked about junctional escape rhythms, and when they became kind of over 60 to 100 or 80 to 100, depending on which book you read, they become known as accelerated junctional rhythms, AJRs. When they get over 100, they're known as junctional tachycardia or automatic junctional tachycardia sometimes. So technically that is an atrioventricular tachycardia. As I say, there's a bit of overlap between the atrial tachycardias and the ventricular tachycardias. So the 2 we're going to focus on for the next little while is AVRT and AVNRT. Hopefully you've all heard these phrases at some stage. So AVRT is atrioventricular re-entry tachycardia, and AVNRT is just adding nodal. So atrioventricular nodal re-entry tachycardia. Hopefully I can just kind of explain very briefly what the differences are here. So let me get my pen. I realise I got the pen next to me and I hardly ever use it most weeks. So we're going to look at AVRT first of all. Now this is Wolff-Parkinson-White is a type of AVRT. And what happens is, so in normal health, you know that your sinoatrial node causes the beat to start really. It's transferred to the AV node through the internodal pathways. The AV node hold on to it for a little while and then it goes down the bundle branches and causes the ventricles to fire. In AVRTs such as Wolff-Parkinson-White, you get this creation of another conduction pathway. So typically it is off the end of this right bundle branch, the Purkinje fibers, the right bundle branch, as they sweep back up towards the right atrium. And it's known as the bundle of Kent. So if this abnormal conduction field or pathway develops, it would be Wolff-Parkinson-White. So the development of a bundle of Kent. And what generally happens, so it's an electrical conduction pathway, and we said before that the only part in one of the first lectures, there's this kind of fibrous skeleton of the heart, and generally in health, no electrical activity can go through that layer except through the AV node. What happens is this bundle of Kent is a second pathway that does allow electrical signals to go through, and that of course causes problems because the AV node is designed to hold on to signals for a little while, in A, to allow the ventricles to fill properly, and B, to allow everything to kind of repolarize in a normal way. The bundle of Kent, when it appears, doesn't hold on to signals for very long. So your signals originating from the SA node shoot through to the ventricles very, very quickly. Does anyone want to throw in the chat, what does that do to your PR interval? So your PR interval is normally fairly long because it's held onto at the AV node for 120 to 200 milliseconds typically. If that signal is coming down and it's going through the bundle of Kent and not being delayed, absolutely matters. It's going to shorten it. It's going to shorten it possibly to 0. Absolutely. So you're all getting that. Fantastic. That's AVRT, Atrioventricular Re-entry Tachycardia. So, and what ends up happening? The tachycardia develops. Let me just get rid of all those red lines a minute. So, the tachycardia develops because in certain circumstances, now normally it's set off by a premature atrial contraction of some sort. What you end up getting is almost like a circular pattern of electrical signal between the AV node and this bundle of Kent. And all that happens is all of these cells around this area are capable of firing their own pacemaker cells. We've talked about that in several weeks. And that is purely a defense mechanism in case the SA node packs up. All these cells are able to produce their own cells. And what you end up getting is this kind of coordinated circular motion between the AV node and this bundle of Kent, which causes lots and lots of activity. If you imagine this is going round and round. The AV node is getting activated loads and loads of times. And the AV node gets completely confused by all this. It doesn't normally have this happen, but it does what it's told, and it fires off signals down the bundle branch block. So what happens if the AV node is sending loads and loads of signals down the bundle of His and into the bundle branch block? You're going to get a tachycardia. So when you end up with this re-entry circuit, you end up developing a tachycardia. Now it may self-resolve. But generally speaking, these are very fast tachycardias, and the body doesn't support it very long. You can reach speeds quite easily of 300 beats per minute, which obviously the body doesn't like. There's no kind of coordinated activity going on. You lose cardiac output, and actually these patients can faint. So the kind of classic thing to look for is the fainting. So Wolff-Parkinson-White is generally diagnosed quite young, so because most people have an ECG at some stage in their life. So your classic patient to diagnose Wolff-Parkinson-White in, I think of the couple of times I have seen it and been the first to see it, have been teenage boys playing football that faint. So exercise. So all this circuit needs is the right trigger to happen. So the trigger can be premature atrial contractions. It can happen completely randomly, or it can happen with stress. It can happen with infection. It can happen with exercise. And this is your classical textbook presentation. Wolff-Parkinson-White is your teenage boy running around playing football and faints. Unfortunately, sometimes they go into cardiac arrest. The ventricular rate gets so fast that it becomes unstable, and you get VTs and VFs. So you do sometimes see VF cardiac arrest as a result of Wolff-Parkinson-White in young children. This is why it's important to pick up. But if you get any kind of exercise-induced syncope in younger patients that probably haven't had ECGs done before, you definitely have to have an index of suspicion for Wolff-Parkinson-White. It is quite rare. But you want to be the one that picks it up, not the one that misses it. Now, as I say, it can self-resolve. You can have a little run of very, very fast tachycardia, lose your cardiac output, faint, have some palpitations or pre-syncope, etc. And then it kind of resolves. You know, the SA node, particularly in these young, healthy patients, is still fairly strong. It's going to start sending signals. It's going to recapture at some point, and they end up back in sinus rhythm. But do an ECG on these patients. Children shouldn't faint when they exercise. So if you see someone young, fit and healthy that's fainted doing some physical exercise, do an ECG, look for Wolff-Parkinson-White. We'll show you some examples in a little while. So the more common of the two re-entry tachycardias is the AVNRT, which is the atrioventricular nodal re-entry tachycardia. And this occurs, as the name suggests, purely within the AV node. We end up getting a reconduction circuit occurring within the AV node. Again, the most common cause of this happening is a premature atrial contraction. It can occur in infection, can occur in exercise and stress, etc. Okay, so it's the same kind of process that's going on here, but there's no creation of this bundle of Kent. This is all just going on within the normal healthy conduction system of the AV node. And I think the next slide just shows that a little bit clearer. Let's clear my board. Okay, let's go. Fab. Okay, so it goes to this first. So we're just going to talk about the junctional escape before we come back to the AV nodal re-entry tachycardia. So junctional escape rhythms. Do you remember this? This was an ECG from last week. I couldn't find any good ECGs of fast junctional escape rhythms to show you, but so this is a junctional escape rhythm with a rate of kind of around 60. So that's normal. If it were to go much over 60 or 80, depending on the book, we would call it an accelerated junctional rhythm. Do you remember? And if that were then to go over 100, we would call it a junctional tachycardia. So that was just ticking off that one that we talked about that was possibly new to you. So automatics, as it's sometimes said, automatic junctional tachycardia is a junctional escape rhythm that's over 100 that's causing tachycardia. Now that could be infection related, that could be electrolyte related, stress related, lots of different things. As you remember, this was an ECG of atrial fibrillation with third degree heart block causing a junctional escape rhythm. So a narrow complex that's slightly slow, that's got no P wave kind of precursor to it. So that's junctional escape. If you want to have a look at last week's ECG lecture, just to refresh on what those are. But if it goes over 100, AJT. Okay, so we talked about Wolff-Parkinson-White on the previous slide. So this is just the slide that shows that. As I say, it shows it better here. So typically off the distal end of the right bundle, Purkinje fibers, which link with the right atrium, and they cause this additional unimpeded electrical pathway to form. And what happens is the signals can travel down the bundle branches up into the Purkinje fibers and then kind of energize the atria. And in the right circumstances, this re-entry tachycardia can occur. This circular circuit between the AV node and this bundle of Kent that's formed, this pathological formation in patients with Wolff-Parkinson-White syndrome. So the cure is to do something to ablate this additional pathway. So, and these are the ECG findings I was talking about. So you get a very short PR interval, so less than 120 milliseconds PR interval. You're always going to be thinking Wolff-Parkinson-White. You can, so typically you do have this delta wave, but it's not always there. The delta wave is kind of a scooping upslope to the beginning of the R wave, and it makes the QRS complex look wide. Actually, the QRS complex isn't wide. The R wave should really start about there. There's just been some kind of upsloping of the PR interval where it's kind of merging into one. So the QRS complex looks wide, but it isn't, and it's because of this upsloping. That's called a delta wave. So the two together are pretty much diagnostic of Wolff-Parkinson-White syndrome. They're going to need cardiology input. I would suggest if they've had a syncope or some kind of episode for you to be there in the first place, that's going to be same-day assessment. They may need an ablation or some other kind of surgery going on. They may need implantable defibs, etc., etc. So Wolff-Parkinson-White syndrome has two types. Of course, it does. Nothing is ever simple. So the most common is type A. It's known as orthodronic, and it's a clockwise motion. So this is simulating your bundle of Kent here to the right hand side of the AV node. and that's why it's also known as right-sided. So type A, orthodronic Wolff-Parkinson-White, is a clockwise circulation motion between the AV node and this new bundle of Kent, and circulating in a clockwise motion. So if we have a look here for a minute, let me just I don't know if I can get rid of that note. So have a look here. So think about if this signal is coming down through the AV node, it's then passing from the right bundle back up through this additional conduction system at the end of the right bundle branch block, Purkinje fibers, and then resetting the atria, and therefore restarting the AV node again and kind of sending that another signal to get going. If you imagine the signals are only entering, in type A, the signals are only entering the ventricles through the His bundle. So do you think the QRS complexes are going to be normal or abnormal in that case? So in type A Wolff-Parkinson-White, the re-entry signal is coming back up, having been through the His bundle. It's come back up through this new bundle of Kent, and then it's repolarized the AV node into kind of sending off. Absolutely, Matt. So if does that make sense to everybody? If the signals are only coming from the AV node down through the His bundle, albeit at a very fast rate, if this is now a Wolff-Parkinson-White induced tachycardia, if that's what's going on, this is going to be a fast rate. But these QRS complexes are going to be normal. You're absolutely right. So because they're coming down the His bundle, they are, for all intents and purposes, just a fast QRS complex. So look at type B then. What's going on here? So type B is the opposite, where actually you get some overspill from the AV node, which shoots down this new bundle of Kent that's been formed and innervates the right bundle. So if you innervate the right bundle, innervate. So if you depolarize the right bundle first, what's the ECG going to look like? Is it going to look normal? Your signals are basically going backwards up through the His bundle into the AV node. It's then shooting out and causing this antidromic, type B scenario, which is an anti-clockwise movement. Absolutely, it's going to be abnormal. In what way do we think it's going to be abnormal? Does anyone want to put it in the chat? So if you start the right bundle branch block going first, abnormal pattern as the flow is reversed, most definitely, John, it's all going to look a bit abnormal. The QRS complex, yes. So you're along the right, absolutely. So we've got a wide QRS and opposite direction. If you innervate the right bundle, do you remember we talked about in ventricular escape beats? If the beat originates from within the right bundle, you see a left bundle branch block pattern. Guess what? Wolff-Parkinson-White type B is no different, because the signal comes down through the bundle of Kent the wrong way into the right bundle branch block, and it starts the ventricles off from within the right bundle branch block. It's going to be wide because it's not going to depolarize correctly, and it's going to look like there's a left bundle branch block because the left bundle hasn't been started off. So everything is going to go as though the left bundle is completely blocked. Does that make sense? So wide and a left bundle branch block pathology in type B. So we've got some examples of that coming up. So this is type A. So diagnostic bits and pieces here. So we've got the short PR interval. If you look in any lead where you can see the P waves clearly, V4 is looking good there, V1 is looking good there. The PR interval is short, it's less than 120 milliseconds. It's more like kind of 80. There is a delta wave. This is what we mean by delta waves. They're really, really obvious. These kind of upsloping PR segments joining into the R wave that make the QRS look really wide. But this is a normal narrow QRS that's the kind of the bit that's going to make the diagnostic for us here. This is a normal looking QRS complex, other than the fact that the PR segment is upsloping and merged into the R wave, making it look wide. It's not really wide, so this must be a type A pattern. Otherwise, the QRS looks normal and the T waves go on to be normal, don't they? Compare that to type B then. So you still have the same diagnostic criteria. You still have a very short PR interval, and actually you can still see delta waves in the leads that allow you to see them. They're basically in V2 and V3. You can kind of see delta waves appearing there. So we've got the diagnostic criteria for Wolff-Parkinson-White. What makes this type B? You've got a wide QRS complex, because actually in these cases, these aren't delta waves, these are just wide QRS complexes. And guess what? We've got a left bundle branch block, haven't we? We've got a dominant R wave type pattern going on in your lateral leads. We've got dominant S waves in your right precordials. We've got the absolutely, and that inverted T wave is discordance, isn't it? So we've got the appropriate discordance. We've got almost diagnostic criteria for left bundle branch block, and we've got Wolff-Parkinson-White. So this is a type B pattern. This is the less common of the two, and this is the antidromic as opposed to the standard one that we looked at first. Also, type B, the more rare of them. But if you see a Wolff-Parkinson-White with something that looks like it might be a bit of left bundle, it's probably type B. Either way, these patients, as I say, if they've had some kind of lead up to this, some symptoms, they're going to need same-day cardiology referral. So this is the other one, LGL, Lown-Ganong-Levine syndrome. Okay, its existence is still challenged. Okay, mainly because people don't understand quite what it is. So the theory that, I'm sorry, it's a little bit blurry, this picture. So the theory is the difference between Wolff-Parkinson-White and LGL is the presence of James fibers. So rather than having a bundle of Kent traveling from the end of the right bundle Purkinje fibers back into the atrium, you have these James fibers that somehow link the atrium to the ventricles in a similar way, but just not from the end of the right bundle branch block like you would in the bundle of Kent. And the theory is that sometimes you can get AVRTs causing as a result of LGL. But as I say, it's not been proven. People don't quite understand what's going on. These James fibers are hypotheses. They're not actually been found as far as we can tell. Everybody learns Wolff-Parkinson-White and LGL, and everybody forgets what LGL is. It's always just the other one. It can cause the same types of rhythm. So the diagnostic difference between them is still a short PR but no delta wave. But then just to confuse things, the absence of a delta wave doesn't rule out Wolff-Parkinson-White. This is why its existence is contested. They're just saying it's just a different form of Wolff-Parkinson-White that we haven't called type C yet. Whether or not we're just going to have Wolff-Parkinson-White type C in the future and we forget that LGL ever exists, I don't know. But LGL is still one of those things that's taught. It's still one of those things to consider. So if you see an ECG, so a history of unexplained tachycardia, and you see an ECG with a short PR interval, but no delta wave, then you can't rule out the fact that it might be LGL. Okay, lovely. And here's an ECG example. Again, nobody knows whether this is for sure. This is the best one Life in the Fast Lane had available here, but you can see a very, very short PR interval, but there's no upsloping PR segment. There's no delta waves going on here. This is just a sinus tachycardia with a very short PR interval. Ordinarily, you would probably think, is this Wolff-Parkinson-White without the delta waves? As I said, not having a delta wave doesn't mean it's not Wolff-Parkinson-White. It's just not conducting in the way that causes a delta wave, basically. But so to consider LGL, you need a short PR interval, a normal QRS with no delta wave, and a history of unexplained tachycardia with or without symptoms. There you go. That's LGL. Okay, so this is where it gets a little bit heavy. So I'll try and keep it nice and simple. So we've talked about the AVRTs, the Atrioventricular re-entry tachycardias that don't involve issues with the conduction system of the AV node. So we've talked about the most well-known of the AVRTs was Wolff-Parkinson-White, which is the formation of a new pathway between the atrium and the ventricles that doesn't allow for conduction delay like the AV node does, and we know that that's a good thing. The heart needs that, and every now and again it gets set off into a cycle, and it causes a very, very fast heart rate and an unsustainable heart rate and symptoms. So AVRT is AVNRT, so the nodal re-entry tachycardias. These are tachycardias that create circuits within the AV node themselves. Okay, so these are far more common. They can be caused by loads of things. So salbutamol, caffeine, nicotine, stress, anxiety, the exercise, PACs, loads and loads of different things can cause AVNRTs. You will probably see them from time to time. You may not notice what they are because they're too fast to decipher, and that's what basically the whole lecture is going to come back to. It's nice to know all these things, but when they're fast, you have to slow them down to figure out what it is. Okay, so so AVNRT then. So in the normal rhythm, so these diagrams explain it quite well. So in normal sinus rhythm, you have a signal come through the AV node. Now the AV node has a slow channel and a fast channel. the signal divides and it goes down the slow channel and the fast channel. The fast channel obviously meets faster, and they cancel each other out. And obviously the net result is just a signal going down into the ventricles. This is what causes the conduction delay. This is basic in very basic terms. What's going on within the AV node in between each beat? There's a signal coming down. It's splitting. It's slowing down, and then obviously it's sending a signal down to the atrioventricular, into the His bundle and the ventricles. So what can happen then is if you get a spurious beat come through, so we're thinking premature atrial contraction or just a very fast heart rate or something along those lines, sometimes you can get an extra signal come down too early. Now what happens is that signal will travel down the slow side, because the slow side, so whilst it depolarizes slower, it repolarizes faster. Remember, there's that opposite anomaly we talked about in some of the PVCs and things like that. So where the slow side depolarizes faster, it depolarizes slower, it repolarizes faster. So it actually allows the signal to start traveling down it. Whereas the fast side is depolarizing slower, as it's still within its refractory period, and won't allow the signal to pass down. So what you end up is a signal from a premature atrial contraction coming through the slow side and entering the AV node. And what can happen, and nobody really knows why, sometimes it does, sometimes it doesn't, because loads of people have PACs and don't go into AVNRT. But what can sometimes happen is that signal just carries on round. So once the fast side comes out of its refractory period, it can be activated in reverse, in effect. And what you end up is getting this signal traveling round and round and round and round and round, just reactivating itself. And guess what? Every time it travels past the exit here, it's gonna start telling the His Purkinje system to start doing some work. And of course, if this is going to go around pretty quickly, that's going to shoot out signals pretty quickly. So you're going to end up with a tachycardia. Okay. Now there's three different types. You can't just have one. So this is known as the slow fast AVNRT. This is the most common. 80 to 90% of AVNRT will be slow fast. You can of course have fast slow, which is the second type. The fast slow is effectively the reverse of this. Now it's less well understood. It only occurs in about 10% of patients. But the theory is that this is activated by premature ventricular complexes coming up the His Purkinje system, being reverse activated. And basically this whole process happening in reverse. And you get the signal going around backwards, and effectively the signal is firing off in both directions. So you get the atria kicking, you get the ventricles kicking at a fast rate. And the system normally self-resolves eventually. Eventually you get a signal come in that kind of resets everything. You get capture, as it would be called. But it, as I say, it does get quite heavy on this one. But slow fast is the typical. That's set off by a premature atrial complex coming down during the refractory period, but being allowed into the slow side of the AV node, not into the fast side until it gets to the bottom. Then it goes through the fast side in reverse, starts to cycle, and it throws off loads of signals down the His Purkinje system. The reverse is true, as if a premature ventricular complex comes backwards up the His Purkinje system and starts the cycle in reverse. You can get kind of delayed atrial activation and some kind of strange layouts. Again, they're not fully understood. I don't think they're fully understood as to why sometimes they happen and why sometimes they self-resolve. And why some patients are more prone to them than others. Now there is a third type which is even poorly understood, which is known as so slow fast. We had fast slow, which is the reverse. You've got slow, but I couldn't find any good examples of that. Slow is basically just a cycle being created through the slow side of the AV node. And the intraventricular fibers that lie around the outside of it. So basically, you get a re-entry tachycardia that's occurring within one side of the AV node in itself, if that makes sense. Again, it's very poorly understood and only accounts for about 1% of AVNRT cases. So the question is, how do we start to try and tell the difference between them? As we start to slow the rhythm, we're going to be able to make out the PQRSs and T waves. So actually, there's a fairly simple way of differentiating between them. So we know that 90% perhaps are going to be slow fast, which is known as common AVNRT. And in those, we're not going to see the P waves. The P waves are going to be buried within the previous QRS complex. So if you look at a fast heart rate that's starting to slow it down, if you're thinking it's AVNRT, if you can't see the P waves, it's likely to be slow, fast, common AVNRT. And as we just talked about, if you flip the cycle backwards, so it's going anti-clockwise, and your QRS complex is going, and then you're flipping the atrium off as well, you're going to see the P waves come after the QRS complex. So that kind of makes sense, doesn't it? So if you see a QRS, then a P wave, then a T wave, QRS PT, you're thinking possibly fast, slow AVNRT. That's probably one of the only situations you're going to see regular QRS PT. The other time we talked about was some premature ventricular complexes that could actually get through the AV node and set the atria off. So when that's happening regularly and it's fast, you're thinking fast, slow AVNRT. Again, it only accounts for about 10%. And then around 1% of cases may have this slow, atypical AVNRT that isn't fully understood. And guess what? It looks the same as every other fast sinus rhythmia, fast sinus rhythm going on. So you're not going to be able to differentiate it anyway. It's not well understood. I couldn't find any good examples to show you. And actually, you're not going to be able to tell what's going on. So very rare, very difficult to differentiate from sinus tachycardia, as you can see there. So the main one you're going to see, so AVNRT is a re-entry tachycardia occurring within the AV node. AVRT is a re-entry tachycardia occurring through a new conduction pathway. Okay, I'm hoping that's made sense to everybody. It's quite a heavy subject, so there's probably a bit of reading around this subject if you're not already familiar with some of the terms I'm talking about on this. So let's have a go. Let's see whether you can pick up then. So we've got Mentimeter again for this. So Charlotte will just pop the link into the chat again. So I'll just get it activated. So this is menti.com 83613. And we just want to know what type of AVNRT is this rhythm here. So remember, you're looking for where are the P waves. If you can't see the P waves, you're thinking one particular type. If you can see the P waves and they're appearing in the wrong place, you can think of another type. And if the P waves seem to be in the right place, I mean, it's the very rare type, or you're looking at something else. So, what can you see P waves first of all? If the P waves are there, are they in the right place? What type of AVNRT do we think we have here? I'll let people have a couple of minutes to look at it. I'm just aware of time as well. I don't want to run over by too much. Let's see how many people have had a vote. So AVNRT. Some of you going for it. So is it slow, fast, fast, slow, or slow, slow? Lovely. So a few of you going there. Let's just show where we're at. Most of you going slow, fast. Some of you going fast, slow. Okay, lovely. Fantastic. So the right answer is slow, fast. So it's slow, fast because I can't see any P waves. If they are, they're buried just at the very end of these QRS complexes in V1. Otherwise, I can't see any P waves popping out at me there. So I think these are buried within the preceding QRS complex, which is immediately making me think slow, fast. There's certainly no sign of any P waves coming between the QRS complex and the T waves, and there's definitely no P waves appearing where they should be just before the QRS complexes. So on the balance of probabilities and the fact that slow fast is the most common, we're going with slow fast in this case. So fast slow it wasn't in this case. So have a go again. See which one you think this one is. So it's the same Mentimeter code 83613. Keep your phones out. Have a look at this one. See what you think's going on. Lovely. So a few of you voting. Have a go with this one. Have a look at where your P waves are. See if you can differentiate what type of AVNRT is going on here. Again, these generally, this is in the process of being slowed down. This ECG would have been taken. So these rhythms are quite quick. You know, you can get heart rates of up to 200 fairly easily. Lovely. So let's see where most of you are going. So, wow, everybody's getting it right. Fantastic. Because I didn't really give you any options, did I? So, but no, absolutely fine. I'm hoping that you're not just doing that on the basis of the last one remaining. But yeah, so you can quite clearly see, and it does look abnormal. These are P waves, and they are increasing. Sorry, the P waves are occurring between the QRS complexes and the T waves, which immediately makes us think this is fast slow, so it's a reverse. So the signal's basically traveling in reverse. You imagine if your QRS complex goes off first and the atria go off second, you're going to see QRS-PT. QRS-PT looks abnormal, doesn't it? And that's it. So yes, absolutely, Matt, you can do that. So increasing to 50 mil per second can quite often help with sinus tachycardias. That's a very good point. So maybe I should put that on my golden nuggets at the beginning. That yes, so what Matt's suggesting is turn up the speed of the printer. ECG machines print typically at 25 millimeters per second. If you make them print at 50 millimeters per second, you're going to get a very stretched out ECG lead. If you look back at ECG series 1, I think the first one we talked about changing the speed in ECGs to look at tachycardic rhythms. So always a good idea. Fab. So we've done that. So the last kind of section is how do we try and tell the difference between SVT and VT, and sometimes it can be very difficult. So we talked about basically most of the time a narrow complex tachycardia is an SVT, but you can have SVT with a wide complex tachycardia, and these are these two guys down here. So SVT with aberrancy. So aberrancy just basically means abnormal conduction. So by abnormal conduction, we could be talking about bundle branch blocks predominantly. So that will cause a widening of your QRS complex. And then of course you could also have pre-excitation. So we refer to Wolff-Parkinson-White and LGL as pre-excitation syndromes. Basically, the AV node is being excited before it's supposed to be, and it's firing off down the His bundle sooner than it should be, and that's why you're getting the tachycardias. So pre-excitation, whenever you see that, we're referring generally to Wolff-Parkinson-White. So you can have a supraventricular tachycardia with Wolff-Parkinson-White and a left or right bundle branch block. That's possible. So these and these are going to look like VT. A supraventricular tachycardia with left bundle branch block is going to look like VT. Okay. So there's some little help points here. The golden rule is always, if you're not sure, treat it as VT. You're not going to do the patient any harm by rushing them to a centre that can deal with VT for them to go and look at it and say that's not VT. That's not going to hurt the patient. Saying it's not VT and doing something else with them, and then they have a cardiac arrest, might hurt them. So let's just drill that into you. If you're not sure, treat it as VT. It's more likely. So these things here, if you see any of this stuff, you're going to start thinking that this probably is VT. And I'll show you some examples as we go through, and then we've got a little quiz at the end to see whether you can spot the differences. So if we're looking at a wide complex tachycardia, or broad complex tachycardia, they're known as both. So wide complex tachycardia, if it doesn't have bundle branch block morphology, so we said aberrancy is bundle branch block morphology. So if you have a supraventricular tachycardia with left bundle branch block, it's going to look like left bundle branch block sped up. If you can't see left bundle branch block or right bundle branch block, then it's more likely to be VT. If it's got extreme right axis deviation, it is more likely to be VT. If the QRS is more than 160 milliseconds, so very wide, it's likely to be VT. If there's no association between the P waves and the QRS complexes, assuming you can see them, then it's likely to be VT. If there's capture or fusion beats, I'm going to show you what capture. So capture beats are random beats where the normal conduction system takes over for a minute. So a capture beat would be a normal PQRST within a C of VT, okay, or wide complex tachycardias, okay. A fusion beat is a bit odd. It can look at a few different things, but basically it's a half-fast capture beat. So it's where where a P wave has travelled through the AV node and started off the His-Purkinje system, but at the same time, wherever this ventricular tachycardia is coming from has also gone off, and the two meet in the middle, and it gives a bit of a weird. You'll see an example of it in a minute. So capture beats and fusion beats are surefire signs that this is VT. So positive or negative concordance, you more often see negative concordance. I'll show you what that means. That's basically in your precordial lead, so V1 to V6, there is either, so positive concordance, when we talk about precordial positive concordance in VT, all of the wave is above the baseline, and negative concordance is all of the wave is below the baseline. So basically you have a big R, no S, or you have a deep S, and no R deep S in the negative concordance. I'll show you an example of negative concordance because you don't see positive very often. So Brugada sign is a widening basically of the S wave as it descends. I'll show you an example of that. And Josephson's sign is notching of the S wave in the precordial leads. Again, we'll have a look at that. RSR, we talked about RSRs in in right bundle branch block, and we said that ordinarily in right bundle branch block, the second R wave is taller than the first. In VT, it's more common that the first R wave is taller than. So if you see the kind of notching an RSR complex in your right precordial leads, and the first R wave is taller than the second, you should be thinking VT. Let's see what all of that looks like. So P wave disassociation. So you can quite clearly see they've put some P waves, mark the P waves on this rhythm strip for us. They're buried within. Trying to decipher VT is very, very difficult, folks. It takes cardiologists a long time to try and figure this out, I'm sure. So the P waves are buried within these VT shark fins that are going on, but there's no association between them. So this can't possibly be a sinus or a tachycardia that's originating from above the AV node if there's no association between the atria and the ventricles. So this is a really good example of a capture beat. So every now and again you get a PQRS with a relatively normal kind of follow on. Obviously it's just gone straight back into VT afterwards. The T wave didn't morph properly. And this is a fusion beat. So you see that there is some attempt to capture beta, but at the same time as this has come down from the AV nodes, this has kind of come up from the ventricles and started its next VT beat. So it looks a bit strange. So if you see some kind of strange levelings off, that's probably a fusion beat. If you see what looks to be a normal QRS complex randomly in it, known as a capture beat. If you see these things, we're more likely dealing with VT than SVT. So this is negative discordance. So you see that the baseline is pretty much here. Oops, I can't draw a straight line on these pads. So your baseline is running through there. You can see the entire QRS complexes in all of these precordial leads is basically below the baseline. All right. This is your negative discordance, and again, this is all negative here. So these are all predominantly negative waves. Again, you can get positive discordance as well, but in this case, the negative discordance is the diagnostic. Again, if you see that, more likely VT than SVT. There's a lot to cover in this, folks. So there's a bit of a whistle-stop tour. So watch back on YouTube later, and there's lots of information on the web about all this stuff. So this was just to demonstrate what these two signs are. So we have Josephson's sign, which is notching of the S wave near the nadir. The nadir is obviously just the base of it. So when you see notching in your descending S wave, you can start to think VT. Brugada sign is an interval, so the start of the R wave to the end of the S being more than 100 milliseconds or 2.5 squares. That is Brugada sign in VT. Excuse me, not to be confused with Brugada syndrome, which we'll talk about next week. And RSR morphology, as you can see, it's not a great image here, but this is an RSR. You can see it there, and the first R is much bigger than the second R. That again starts to makes you think this probably is going to be in V1 or V2 by the looks of things. You would see this in more so in VT. So this is another question for you then. So this is to try and put a bit of that into practice. So is this SVT or VT? It's the same Mentimeter question. So what's your diagnosis here? Are we thinking anterior MI, sinus tachycardia with left bundle branch block, VT, sinus tachycardia with right bundle branch block, or are we thinking Brugada? So have a little look through those rules we just talked about. So is the complex more than 160 milliseconds? Is the PQRS disassociation? Are we seeing any of the bundle branch block morphologies? Have a little look at that, see what you can think. Is this SVT with aberrancy, or is this a VT? Lovely, good, few of you voting. We're up to, lovely, let's see where everybody's going. So most of you saying that this is VT, okay. Anyone else want to have a go before we talk through this? Jumping on the bandwagon with VT there, okay. We'll go back to the previous slide. So most people thinking this is VT, not an SVT with aberrancy, okay. So first thing first when we're trying to figure out whether something's coming from above the ventricles, the first question is, can we see P waves? No. We can't really see P waves. They may be buried within the QRS complex. We just don't know what's going on in this case. Okay. Is the QRS complex wide? Well, it is wide. It's over 120 milliseconds, but it's not wide. It's not 160 milliseconds or more. So I'm thinking less likely VT from what we're looking at here. And you remember, if this was a true VT, you wouldn't see any signs of left or right bundle branch block, would we? And what do we see here? We see a wide QRS with a dominant S wave and an appropriate discordance. We see a dominant R wave with appropriate discordance in the lateral leads. This is left bundle branch block, is it not? So if we're seeing left bundle branch block and the QRS complex isn't actually wide enough to be a full-on VT, do we think perhaps this might be sinus tachycardia with left bundle branch block? Did I catch you all out, or have I just not taught you anything? Well done, Andrew. Perfect. So this is sinus tachycardia with left bundle branch block. If you're seeing bundle branch block morphology in a fast, wide, complex tachycardia, it probably isn't VT. But if in doubt, treat as VT. That's the bottom line. But in this case, this is sinus tachycardia with left bundle branch block. As you would have slowed it down, you would have seen the P waves start to appear, and this patient would have had underlying just standard left bundle branch block. They were just a bit tacky for whatever reason. So lovely. So here we go. Have another go at this one. So what do we think is going on in this case? It's the same Mentimeter code. So your options are the same: anterior MI, sinus tachy, VT, sinus tachy of right bundle, or Brugada. This isn't as straightforward as it first looks. Those of you that have been following the kind of the gems that were on the slide before about how to try and tell the difference. This one just proves that all rules are infallible. Interesting to see where you're going with this. So have a look for P waves. If you can see P waves, see what they're up to. If you can see, have a look at things like the width of the QRS, have a look at your axis, have a look at RSR complexes, have a look for things like right and left bundle branch block, have a look for notchings of the S waves, have a look for wide QS RSs, the Brugada sign. Let's see where folks are going with this one. Lovely. So let's see where we're all thinking. evenly split with VT and sinus tachy with right bundle, as I thought we would. Okay, let's have a look then. So this doesn't. So this doesn't quite conform to the rules, this ECG. It's an interesting one. I'm just going to get the pen rather than the mouse because it's easier. So what's going on here? So first things first, we have got a very wide QRS complex. That's fine. So QRS here, let's say, is getting on for 160 milliseconds. So we're thinking probably VT, aren't we? Okay, fine. So then we start to look. So we start to look at axis. So we have negative. We have negative. We're looking in the extreme right axis deviation, aren't we? Or northwest axis. So that puts us down the line of VT. So V1, I suspect that's a P wave. That's a P wave. I'm not entirely sure that there's any coordination. I don't think that is. I think that might be. There doesn't appear to, if those are P waves, there doesn't appear to be much association between the P's and the QRSs. So I'm still thinking down the line of ET. But what's going on here? So we've got potentially right bundle branch spot there, haven't we? So we've got an RSR with the first one lower than the other one. What else have we got that kind of makes us think? There's not much else we can really decipher from this ECG. I'm not sure those are P waves. If they are, there doesn't appear to be much in the way of association going on. We've got the extreme right axis. We've got the very wide QRS complex, but we've perhaps got right bundle branch spot going on. So what's actually going on in this case? Nearly everything is negative. You're absolutely right, John. So it's not quite the case. That's definitely a positive QRS. That's a positive QRS. Everything else is negative. There's not quite all over the place. Yeah, so Habiba, there's something going on in the right bundle branch spot. This is VT. Okay, so the diagnostic from this one was that these were P waves. That there was AV dissociation. There was extreme right axis deviation. When they slowed this rate down, the patient didn't have right bundle branch block. So this was a VT that just broke some of the rules. So. And I like to end. I know, sorry, Habiba. I like to end this one because actually it does show you that if you're in doubt, treat as VT, because you can get yourself really stuck with these things. This is a really hard ECG, and we've been getting progressively harder as the week's gone on. I think the one we ended up on last week made a few people cry, and I think if I saw this one at 2:30 in the morning, I'd cry. So it's one of those ECGs that if this patient is symptomatic and an ECG like this, they need a cardiologist. They need somebody to look at this and see what's going on. Like everything, they need it slowed down before you can decipher what's going on. It just so happened when they slowed this one down, they didn't have right bundle branch block. That was just an obscure finding, and we may never know why that occurred. So. This is VT. It meets more rules for it being VT than it doesn't. So, so well done to the half of you that's got that. So if it'll let me go forward. Okay. Oh, look at that. Oh well. Let me get rid of my drawings. There we go. Fab. So of course the correct answer was VT. Well done to everyone there. And that's it, folks. So that's been a heavy subject tonight, and I was a bit worried when I was writing it that it was quite a lot to skim through in an hour. I suggest anyone that wants to have a better understanding of this is going to need to do some pre-read or some reading around it, and maybe watch the video again after a few days. If there's anything you want me to go over again, so next week we're going to talk about cardiomyopathy and Brugada syndrome. Not to be confused with Brugada sign and Brugada pathway or whatever it is, but the Brugada diagnostic tool that comes up. Brugada invented a lot of things. So next week, at the same time, Monday the 29th of June, 7 o'clock, we're going to do cardiomyopathy and Brugada. For those of you that don't want to join in with the Q&A, you can leave us now. If you'd like a CPD certificate, then do drop us an email to webinars@stctrainingsolutions.co.uk. I'd imagine there's going to be a few more questions than normal after that kind of whistle-stop tour through some complex stuff I hope the take-home point is, if it's wide and fast, treat it as VT until you can prove otherwise. If it's fast, slow it down, and then you might be able to figure out what's going on. As Matt has said, and we said in week 1, if you're struggling to see what's a P wave and what's not, sometimes printing faster spreads it out a bit and makes it a bit clearer. There are a few little tips like that. And generally, narrow complex tachycardias are less of a problem than wide complex tachycardias, the exception being Wolff-Parkinson-White, which can lead to unstable ventricular arrhythmias. And as I say, definite take-home point there is younger, it seems to be male patients more than female patients get Wolff-Parkinson-White. Younger patients that collapse, they need an ECG and looking for Wolff-Parkinson-White. So for those of you that are leaving, thank you very much for coming. It was very kind of you. Please do leave us a review, as always. If you're new to this and you haven't dropped us a review, I'd be very grateful if you could. It just helps customers find us. Obviously, we'd like to keep all this free. You're more than welcome, everyone. Thank you for coming along. Feel free to watch us on YouTube a bit later. More than welcome. And any questions, then please feel free to pop them in the chat, and we'll do our best to answer them. No, no obstacle. No, it's not dangerous. It is plain and simple. It's just the SA node has been taken over by another bunch of pacemaker cells. Now, that's not generally going to cause any symptoms. The fact that it's fast, you need to start thinking about why is it fast. But it might just be fast because the patient's exercising or would have had a sinus tachycardia anyway. It just means for whatever reason the SA node has been taken over by somewhere else in the atrium. What can often happen is that those patients then degrade into atrial fibrillation because everybody starts having a free-for-all within the atrium and they all start sending off signals. But unifocal atrial tachycardia is just a sinus tachycardia, for want of a better, for all intents and purposes. So no, not dangerous. More than welcome, Habiba. The answer to the week's question. So John, so technically it was how many beats? Five PVC beats, wasn't it? So it was more than 3 anyway. So it was non-sustained ventricular tachycardia was the diagnosis. But yes, they were PVCs. More than 3 PVCs in a row is, or 3 or more PVCs in a row is NSVT. Hi Jen, yes, I think I was calling you No last week, and then I realised that wasn't an Oriental name. That was no obstacle. It only came up with the first name last week. So Jen, the management for AVRT, Wolff-Parkinson-White is generally ablation. It's cardiac, so it's going to be in interventional cardiology to try and stop that pathway through ablation and medications and things like that. Half the issue is picking it up because quite often these patients have symptoms that they ignore and they ignore and they ignore, and then all of a sudden they have some unstable ventricular rhythm and present quite unwell. So that's why we're saying it's an indication for an ECG. Any kind of exercise-induced syncope is for obvious reasons. You're going to have a look at the heart rate. So there's no kind of pre-hospital management of AVRT or AVNRT. AVNRT is not a problem. It generally self-resolves. It's the most common cause of palpitations. So pre-alert, absolutely, Dave. I would be thinking pre-alert with a patient in an AVRT. So something we're thinking is secondary to Wolff-Parkinson-White. The bottom line is you're probably not going to know that whether this is an AVRT or an AVNRT just from looking at a fast ECG. You're going to see a narrow complex tachycardia. If the patient is symptomatic, like anything, if the patient has an abnormal ECG and they're symptomatic, they're unstable, we pre-alert. If they're stable, then it's your local guidance on what they say. We by and large we pre-alert too many patients in, don't we? But if they're unstable and they need a resus team when they get there, absolutely. And AVRT is going to be. Does differentiating the type of AVNRT affect? No, absolutely not, Jen. It doesn't. So you're not going to treat them any differently. So don't forget, a lot of the stuff you're learning in this series isn't necessarily going to change your treatment pre-hospitally. It just gives you an idea of what the underlying problems are and what might else be wrong with your patient. Patients that are picking up lots of kind of bundle branch blocks and things like that we've learned about over the weeks are likely to have underlying ischemic heart problems, and you're, you know, particularly when you get into prescribing and things like that, you're possibly going to be a little bit more cautious with what you prescribe. Pre-hospital care in terms of ambulance service, knowing what type of AVNRT your patient's in isn't going to help you in the slightest. If they're symptomatic, you take them in. If they self-resolve and they're not symptomatic, then perhaps get them off to a GP referral for cardiology routine. I don't know. It's you know, possibly not going to affect. So putting a cannula in. So yeah, prophylactic cannulas or precautionary cannulas. So this is always a debate, because technically the trust I work for says we don't put precautionary cannulas in, but then if you have reasonable belief that your patient is going to deteriorate to the point of needing a cannula, you can put one in. Well, I defy you to define prophylactic cannula without saying something along the lines of expecting your patient to decline to the point of needing a cannula. That is a prophylactic cannula, isn't it? So I dare say your trust, if it's not London, is probably thinking along the same lines, Jen, that they say you don't put a cannula in just because. But if you've got a patient that you have a reason to think might deteriorate, then you're more than welcome to put a cannula in for a VT. I would definitely say a patient in VT is getting a cannula, whether you want to call it a prophylactic cannula or not. That patient's not well, are they? So if they arrest, you're going to be thankful of it there. Valsalva maneuver works on vagal tone. So if you think about the electrophys, your vagus nerve innervates only the SA node and to a small part the AV node. If the tachycardia is originated from below the AV node, dropping or reducing your vagal tone increasing your vagal tone is going to do absolutely nothing, is it? So no, your Valsalva maneuvers are only going to work for narrow complex tachycardias generally, or SVTs. No problem, John. Good night. Nice to see you again. No problem. Any other questions from anyone before we close up? Oh, more than welcome, Dave. So they're all up on YouTube if you want to go back to the beginning. I'm glad you found us. As I say, we will be looking at doing more series in the future on different subjects. And I dare say, because ECGs are such a popular subject, we will probably be looking to repeat the ECG series at some stage. Obviously, I wouldn't imagine it'd be for some while, but the whole idea of having the interactive element is quite good for ECGs. I think there's loads and loads of YouTube videos out there. There aren't that many kind of interactive ones that I've found so far. So. More than welcome, Alan. Good night. Okay, so no more questions. That's fantastic. I'll stop the recording there.